Alaikum wa rahmatullahi wa barakatuh. Good evening, colleague, friends everywhere. Welcome to GIS conference virtual this year. Inshallah, will be physical soon. I'd like to welcome you to the special meeting. It's sponsored by Medtronic. So the risk factors we know: hypertension worldwide, affecting every three of us. One is hypertensive, and the problem is adherence to the medication, and morbidity is very high. We have a solution. We have experts here to take us step by step how we can make hypertension management simple, but through the device. It's called RDN. And for that, I have my colleague and friend, Dr. Khalid Al-Mirri from Chest Hospital, and Dr. Ahmed Imam, both going to show us live in box, step by step. This is what we need. We're going to enjoy this in 22 minutes, then we'll come back for the question and answers. So, Dr. Khalid, we're looking forward to your live in box.
Hi, I'm Dr. Khalid Al-Mirri from Chest Disease Hospital. It's my pleasure to work today with my friend Dr. Imam, Ahmed Imam, and we are going today to perform renal denervation, and we are going to go over the procedure step by step to perform a step-by-step renal denervation with Symplicity spiral catheter in a patient with resistant hypertension. We'll start now with the case presentation. My colleague Dr. Ahmed will present the case.
Hi, good afternoon. Our patient today is 62 years old, female patient with diabetic, dyslipidemic. She has a history of CABG 2019, 2 years ago, and she has a long-standing of uncontrolled resistant hypertension. Patient has an average office blood pressure measuring of 180 over 100 millimeter mercury. Her creatinine is 80 millimole per liter. Her estimated GFR is 140. She's on Codiovan 160, Diovan 160, Modiuretic, Aldomet, Minipress, Norvasc, Tenormin, plus her aspirin and Crestor 20 milligram once daily. Her ECG saw sinus with LVH. Her echo showed normal LV ejection fraction with basal and septal LV hypertrophy.
We'll go over what we have done so far in the preparation of the procedure. We have our colleagues from anesthesia to help in pain management, sedation, and analgesia, because this procedure can produce pain during the procedure and patient can feel uncomfortable. So what we have done now, abdominal aortography, and we use abdominal injection. We could do CT scan pre-procedure to delineate the anatomy of the renal arteries, but here we chose to do the abdominal angiogram. And there is a reason for that. Maybe Dr. Ahmed can tell us why we need to do a CT scan or abdominal aortography.
Yes, we do aortography or CT scan pre-procedure, of course, just to be confident that we have a single renal artery supply for both or one kidney, because the accessory renal artery, if it's there, it's like 20 to 30% common. So we need to exclude the presence of accessory renal artery.
So basically, having an accessory renal artery is common. And if we find a suitable accessory renal artery, it should be ablated like any renal artery. After that, we did selective renal artery angiogram, and we did the right and the left. So we did selective left renal angiogram. That's what we see here. You can see the ostium of the renal artery has some disease. We injected Tridil, and it should be a standard treatment that we give before we start the ablation to rule out spasms, and to sometimes we avoid spasms by introducing the catheter and wires. And then we can see there is a big superior inferior branches after the first bifurcation, and the lower branch has another bifurcation just shortly after the second bifurcation of the lower branch. The vessel goes into the parenchyma of the kidney. And then we did a right renal angiogram, if you can see that. And you can see the kidney is lower in the abdomen. Still, it bifurcates into good-sized vessels, and this is the position of this kidney being a lower in position doesn't preclude her from the procedure. So we used a RDN guide, 6 French, 55 centimeters. We can use IMA guide. The length can be 45 to 90 centimeters is acceptable, but the regular guides will not be suitable for the procedure because it will be longer than the Symplicity catheter. So what we have used here is RDN 6 French guide. We used a wire which is a BMW wire. You can use any floppy wire provided it's not hydrophilic wire. And the reason for that, we don't want to injure the tissue of the kidney. So we have the wire in the lower branch of the renal artery. Then we also did the measurement of the vessel. So we did the measurement of the main renal artery and the upper and lower branches, and we can see the size of the main renal artery ranges from 5.3 to 6.4, and the branches ranges from 3.7 to 4.7, which is really acceptable. What we need for the procedure is a vessel size between 3 to 8 millimeters. I should mention that we gave heparin. We need to keep the ACT 250. And as I mentioned earlier, we gave Trideal into the renal artery, and we gave sedation and analgesics. So now we have the Symplicity spiral catheter. We are ready to use it. We should not flush the hub, and we don't need to do that. It's a rapid exchange catheter. It is, as you said from the name, it's a spiral catheter. Has 4 electrodes. You can see 1, 2, 3, 4 electrodes on that spiral. The tip is soft, atraumatic tip. And now we have to load this over the wire. So you can see it's going to be difficult to load it on the wire here. So that's why we have an orange plastic tube to straighten that loop. You can see as we come closer, the loop will come inside to help us to load the wire. We need to keep a few millimeters of the catheter outside. And as I mentioned, it is a rapid exchange. So the moment I have the wire outside, you can see the wire came outside from here. The moment we have the wire outside, we need to pull this orange plastic back to the original spot. If we just continue to go in, then the orange will be on both the wire and the spiral catheter, which we don't want to have that. So I'm going to hold it that way. I'm going to take the plastic part back to the original position, which is at the end of the catheter. And now we have our catheter over a wire here, and then we are ready to insert the catheter. You can see as the Symplicity catheter came out of the guide after the exit of the 4th electrodes, now you will start to see the impedance on the screen. So now we'll talk about the screen now. The screen has 4 lines which represent each electrodes on the catheter, and you will see there during ablation the impedance means how well opposed to the wall, tell you how well opposed to the wall of the artery. And then with ablation you will see the temperature rising and you'll see the amount of impedance drop during ablation, which we will talk later on about. This is the generator. It has a remote here that enable us to control the ablation with this remote. So it has 4 buttons which represent the 4 electrodes. It has the RF button to start ablating, and by this we can control each electrode, turn it off, turn it on, and we can turn off as any of the electrodes. We can do in the middle, you can do it from the beginning or the end. So now we're going to go inside to the location that we chose, which is going to start with the lower branch of the renal artery. And you can see the wire should be always ahead of the catheter. Now we are in the position that we want to start with, which is the lower branch of the renal artery. We'll inject to see our position. That's a nice position, right?
Yes.
But when we pull the wire, the electrode or the catheter will come back a little bit. Now we'll take an image here to see where exactly we are going to ablate. Okay, Dr. Ahmed, we have the 4 spots of the 4 electrodes. We can see the impedance is good there and stable. Yeah. So when we are not against the wall or properly opposed to the wall, we can see the impedance variation is big. So it should be steady impedance with variation is minimal. Here it is really steady here.
Yes.
Now looking at the angiogram, do you think we should go with the 4 electrodes, 2, 3, or what's your plan here?
Yes, as you said, Dr. Khalid, we should go for any vessel between 3 and 8 millimeter, but should be also outside the parenchyma. So if we can see here the 4 dots, the one the most distal one is actually is inside the parenchyma. So I think we should start to ablate 2, 3, and 4. Yeah. So we can deselect the one, the most distal one, and go with the other 3.
So I totally agree with you, Dr. Ahmed. Electrode number 1 could be in the parenchyma. So I think to be on the safe side, we will not ablate that one, but we will go ahead with 2, 3, 4.
Yeah.
And 4 we can see it is distal to the bifurcation, so we can go with it. So what we do here is deactivate number 1. So we will ablate in 3 spots. And we are ready to do the ablation. I should mention that we can control this through the remote or through the touch screen. So we're ready. So basically we press the RF button. Then we can see for 1 second start ablating. This is the time when the patient feels uncomfortable. And we see on the screen the percentage of a drop of the impedance, which is fine. The impedance, you can see it going down, which is the white line, and the temperature goes up, which is the blue line. And that's what it should do. And you can see channel 1 is off. We're not ablating at that point. So we chose to ablate with 3 electrodes. You can see the second electrode drop in the impedance is not really as what we wanted, and the rise in the temperature less than the others. So at 5 seconds from ending, it will just be like that, tell you that we're done. So we have done the first ablation. Now we should bring the catheter back between the second and first bifurcations. The catheter should be advanced and pulled over the wire all the time. This is the second ablation. We can see the 4 electrodes are between 2 bifurcations. and we can see the impedance, they are well opposed, and we are ready to ablate. So basically, if the size of the vessel is not suitable, as Dr. Ahmed said, and if there is severe stenosis, or if there is previous intervention like stenting, or if the artery has an aneurysm, that those vessels we should not really ablate. So now we're ready for the second ablation.
Do you think number 4 على bifurcation?
Yeah, so Dr. Ahmed is telling me the number 4 electrode is close to the bifurcation. I totally agree with him.
So we
can deactivate the number 4 here, and we ablate the 3 spots. And we're ready to ablate. Again, we press the RF button. We should mention, as the vessel becomes smaller, the area of ablation becomes longer, which is that loop will be stretched. As the vessel becomes bigger, the area of ablation will be shorter. So you can see this one is like a stretched loop by covering longer area. Again, if we look to the ablation parameters here, we can see temperature is rising nicely, and the impedance coming slowly, nicely. And I think that's a good ablation here.
Yeah.
Excellent. Now we have wired the upper branch. You can see the catheter is in the guide now. You can see the screen is nothing on it, no impedance. As I mentioned, when we are in the guide, we don't see the impedance. Now we will go to ablate the upper branch of the renal artery. Can go up, Dr. Ahmed. Basically, with the aerial experience, we used to ablate the main renal artery. And we learned that the sympathetic nerves are coming closer and more abundant to the distal branches. So we know that there are some nerves that we call late arriving nerves, that they start from the base of the root, and they are really away from the renal artery. As they come closer to the distal part, they come closer to the artery. And those, if we ablate into the main vessel, we may miss ablating them. So basically, in the distal branches, we have the nerves closer to the arteries. They are more abundant, and we can ablate the nerves that are called late arriving nerves. Back to the upper branch.
I think
So I think we are good here.
Yes.
The other thing patient might have is bradycardia. So sometimes you may have, with ablation, you may need to use atropine. We're ready for the ablation of the...
I'll take my wire out now.
Yeah. One important point, when we pull the wire out of the catheter tip, we have to bring the wire back proximal to the proximal dot, but we don't bring it too much back, because if you pull it too much back, you will come out of the rapid exchange port. So then you cannot wire the catheter. So you just go a few millimeters proximal to the proximal electrode. So this is our third ablation run. And we have ablated 6 spots before this. And now with this ablation, now we are 10. The average ablation points per patient in the previous studies close to 45 ablations. And with this image here, we can see the electrode at number 1 is at the same point that we ablated in the previous run. Usually we try not to ablate the same spot twice. Theoretically, it may cause more damage. We have no data for that. So we are avoiding ablating the same point. So we are not going to ablate number 1. We will ablate number 2. We will ablate number 3, which is before the bifurcation, and number 4. So we'll cancel number 1. See here, we have one channel. Number 1 is we turn it off, but number 4, it says insufficient temperature, which means there is no enough contact to the wall, which is fine. We'll go back and ablate that. The other thing, sometimes when you go in, you don't have good contact. So you have to manipulate your catheter, especially with breathing. Patient can move the catheter with breathing. So if you have no contact, you can just go and clockwise the catheter, so to take the shape of the artery, come closer. And you can see you have, when you lose the contact, you get a red color on the buttons. And now we are going to ablate the main renal artery. We can see the electrode number 4 was ablated with the previous run. So we'll do number 2, 3, and 4. We can see the impedance and the catheter, the electrode number 2 is not stable. Can you see that? So in that case, we can slightly torque the catheter clockwise. See, it became more stable, right? You can see that, right?
Yeah.
Now we're ready to ablate. So by that we have ablated the main renal artery, the superior branch of that artery, and the lower branch. One thing, important step that we have to finish with is to do renal artery angiogram to rule out dissection, thrombus, or any complication that we could have done, which is usually very rare to have those kind of complications. We can see the angiogram now. Sometimes you can see that beading of the arteries will give nitro. You can see the superior branch ostium has some narrowing. We are going to give Trideal and we see if it improves or not. You can see after nitro that spasm has improved significantly. Okay, but by that we have demonstrated renal artery denervation with Symplicity spiral catheter. We have done one side. We are going to proceed and do the other side offline.
Now when we are done with the ablation of the renal right and left renal arteries, we can get a USB and connect it to the generator, so we can retrieve our procedure data, the procedure time, the amount of dropping of the impedance and the rising in temperature and the numbers of the ablation that we've done, and use this for analysis and follow-up of our patients and analysis of our data.
And thank you for inviting us and allowing us to show this interesting procedure step by step.
Thank you very much.
Well, outstanding. That was great, really, Dr. Khaled. You know, step by step. I've seen many live cases, but this was really a real practical one and really made it very easy for us. So, Dr. Khaled, you know, one of the beautiful steps, and one of the things, you know, people worried about the safety and the, you know, pain the patient will get through these procedures, you know. So tell us how we can, you know, reassure the who are participating in this meeting about the safety of this new tool we have now, RDN, which is highly advanced, and of, you know, the evidence there, randomized clinical trial observation telling us about safety and efficacy. But I want to know in real life, you've been using this for some time now, and this live inbox was beautiful. Tell us about.
Regarding safety, we did not have any issues with that. And our experience is the same that we have from the trials, that I don't recall that we had any dissection or any thrombus formation or any problem. The access site complications is like any other femoral angiogram. But in our center, we use it as almost routine that we do the femoral axis with ultrasound guidance. And using that, I'm sure that it will decrease your complication rate. And if you use an ultrasound, at the end, you close it with closure devices. So your risk of bleed complications is low. But the procedure itself, the only thing is the pain, but you have to know how to control that pain. Like in this patient, we got the anesthesia here, maybe because of the recording, and the patient didn't feel anything actually, and she didn't, move or feel anything. But we usually give the sedation analgesia. Sometimes the patient will feel the pain, but they will not remember it because they will have, the amnesia of the drugs. So control the pain, no other issues actually after that.
Great. So for those who are now, seeing the evidence, seeing the live in box and want to, start this the program in their center, what do you advise? What should we do? Which patient should we choose start with to get,
I would ask Dr. Ahmed this question. I will direct it to him, since he started with the arrangement of the clinic, and most of the program is run by Dr. Ahmed in our center.
Yes, Dr. Ali. Yes, Dr. Abs. Actually, when we started to do our RDN program, we started like a hypertension program. So we started with hypertension clinic as a core of this program. We started to enrollment our patients, and we accept patients from our general cardiology clinics and from our other hospital referrers. Actually, the indication that we have in our clinic for renal denervation now, the resistant uncontrolled hypertension. As you know, there is another indication for the RDN, like intolerance to medications or patient preferences or something like this. But for our policy in our center, only for resistant uncontrolled hypertension, the indications for our patients to enroll for renal denervation. And we take a complete history from the patients. We rule out any secondary causes of hypertension. Then after that, we talk to the patient about if he is diagnosed as as a uncontrolled resistant hypertension. We can confirm with ambulatory blood pressure, 24 ambulatory blood pressure. Then when we reach this diagnosis, we talk to the patient that we have another solution for his problem. We speak to him as our data that we have from studies nowadays. Then we send him for the procedure. Of course, after the procedure, we have follow up the patient 1 month, 3 months, 6 months, and 5 of our patients now, they already reached like 1 year follow up after the procedure. So this is our, in brief, our hypertension program in Chest Disease Hospital.
Beautiful, and really nice to also to see these cases be presented, as a series rather than just. But beautiful, Dr. Khaled, Dr. Ahmed, please last take-home message from you both before we end, because you are reaching the end of the program.
And I think, as you said, it is a safe procedure. It's effective. The problem is we have to let the medical society aware of it. So it's not people or patients, it's basically the medical society is, I can call it illiterate about the renal denervation. So I think we have to go and get out and reach out of them and teach them that we have this technology.
Ahmed?
Yes, now fortunately we have a new solution for hypertension. Hypertension is not a benign disease, it's a malignant disease. It has a lot of consequences. So fortunately, in the future, with more follow-up of the patient, more data that we will have, so it will be very beneficial for those type of patients in the future, inshallah.
Thank you very much, both of you. Thank Medtronic See you inshallah. Take care.